right. Thank you guys for having me. Dr. Josh Gonzalez. I always like to ground lectures like this in a bit of history, some of which a lot of people have alluded to. I also am not as old as Jorge, but am old enough to remember a time when a talk like this would not have been possible, when the focus in treating patients with HIV was merely survival. And fortunately, a lot of advances have been made thanks to a lot of people in this room. Um, and now allow someone like myself to interact with this patient population because so many people living with HIV are now living for decades and really want to focus on their quality of life. And that's sort of where I come into this story. Um, Urology and sexual health sits at this really cool intersection between, longevity, health and wellness, relationships, identity, dignity. And so I feel very lucky in the work that I get to do, especially with patients living with HIV. A little bit about myself, some of which Jorge covered already. I'm a private practice urologist based in Los Angeles, where I was born and raised before I headed to New York to complete my medical education. At Columbia, I spent a year as a Doris Duke Clinical Research Fellow doing projects around prostate cancer. That's when I first became interested in urology, and also the first time I started to see real health disparities in patients living with HIV, specifically around prostate cancer diagnosis and treatment, and then moved across town to Mount Sinai, where I completed my urology residency, and then came back to California, where I did a one-year fellowship in sexual medicine. A lot of people don't know what sexual medicine is, and I get asked all the time, what exactly do you do? What does that mean? Sexual medicine is this sort of multidisciplinary area of medicine that I feel very lucky to be a part of. And my job every day is to help people have better sex. I treat people of all genders. I treat patients with a variety of sexual health issues, many of which can be very, very complicated. And so I have to think sort of comprehensively and think outside of the box a lot of times to help treat these patients. Some of my specialties are listed there for patients who are assigned male at birth, but I definitely interact with patients who are assigned female at birth. I do a lot of work in perimenopause and menopause as well. In addition to my clinical work, I co-founded a company called Popstar Labs, which is a men's sexual health and wellness company, to try to help patients find real-world solutions for the problems that they were seeing and dealing with, even once they left my office. I have no relevant financial disclosures. So here are the learning objectives for today. We're going to cover a lot, but hopefully at the end of this talk, you will understand how HIV and aging uniquely impact urological and sexual health. You should be able to identify common urinary and sexual disorders in aging men with HIV, to apply evidence-based evaluation and management strategies, and then to be able to incorporate antiretroviral interactions and quality of life considerations when counseling your patients on their urological and sexual health complaints. Why does this matter? This has been brought up a number of times today, but we're seeing a growing group of men live decades now with HIV. That also means that comorbidities are on the rise. At this point, over 50% of people living with HIV are over the age of 50. So their interactions with a urologist and a sexual health provider like myself are becoming increasingly common. This means, we know that earlier onset of comorbidities occur in patients living with HIV compared to their HIV negative peers. There also is a higher prevalence of hypogonadism, sexual dysfunction, and they're at increased risk of multimorbidity. Urologic conditions also interact not only with HIV as a virus, but the antiretroviral therapies that people are put on, as well as cardiometabolic risk and polypharmacy. So let's look at the numbers. The prevalence of hypogonadism in men living with HIV it varies, but it's anywhere between 13 and 40%, with some meta-analysis estimates putting it around 30%. The prevalence of ED also varies, but it's somewhere in the 30 to 40% range. And it's important to understand, and we'll cover this in a little bit, that men with HIV have different cancer risk profiles, especially as they relate to genitourinary cancers. Prostate cancer incidence, interestingly enough, may be lower in this group, And we think that's for a couple of reasons. Patients with HIV tend to have less frequent PSA testing, therefore they undergo less frequent biopsies and they get diagnosed with cancer less commonly. However, and I'll talk about this in a little bit, when they present with prostate cancer, it's often at a more advanced stage. So, what is the interaction between aging, HIV, and the genitourinary system? Well, it's been talked about a little bit today, but there's a chronic inflammatory state, there's immune activation, and of course, the medications that we use, all of these can contribute to end organ aging. There's also, as people get older, higher rates of metabolic syndrome, cardiovascular disease, and endothelial dysfunction, which becomes incredibly important, especially when you're talking about something like sexual function. Factors like autonomic neuropathy and psychosocial stressors can also play a role. And then, of course, polypharmacy and drug-drug interactions must be taken into account, especially when you're starting to add medications to help patients deal with urologic and sexual health conditions. So let's give some real clinical examples. BPH and lower urinary tract symptoms, something that we see quite commonly, BPH or benign prostatic hyperplasia. The prevalence for all men increases with age. However, symptomatic lower urinary tract symptoms are even more common in people living with HIV. HIV positive individuals are also more likely to report higher bother scores from those urinary symptoms. When we talk about urination, we talk about storage symptoms and voiding symptoms. Storage symptoms are things like frequency, urgency, nocturia. They're sometimes called irritative symptoms, compared to voiding symptoms, which are things like hesitancy, weak or interrupted stream, feeling like you don't empty your bladder well, or post-void dribbling. Those are sometimes called obstructive symptoms. And so we ask patients about these symptoms in this context. There seems to be an earlier onset and an increased symptom burden in patients living with HIV. So you may want to consider asking about these symptoms earlier in this patient population compared to HIV negative men. And in terms of an evaluation, the things that we look at are avoiding history, the International Prostate Symptom Score, which is a validated metric that we use in urology. You want to look at a urinalysis to rule out things like infection, screen for blood in the urine, and then we always check a post-void residual if we suspect obstructive symptoms to evaluate how well someone is emptying their bladder. How do we manage this in patients with HIV? It's pretty similar to HIV negative patients. Alpha blockers remain the gold standard. They provide a rapid symptom relief. However, and this is true for any of the medications that we use in urology, I approach this from a little bit of a different vantage point because I'm specifically interested in optimizing someone's sexual health. These can carry some degree of ejaculatory risk. So with a medication like Flomax or Tamsulosin, the generic, you're talking about a 20 to 30% risk of retrograde ejaculation in patients who use this medication, which if you appropriately counsel someone, they may not care about. They may have already noticed a decline in their ejaculatory volume over time, which we'll get to in a little bit. But if you don't tell them about that, and many urologists unfortunately don't have that conversation and they experience that, it can be incredibly distressing. People don't understand what's happening, and it can have a negative impact on their sexual function. So counseling a patient is incredibly important. Thankfully, there are other alpha blockers that carry a slightly lower risk. So you could switch them to a medication like alfuzosin and drop that risk to about 2 to 5%. Either way, if someone experiences retrograde ejaculation, this is a reversible phenomenon with these medications. And so if it is incredibly distressing, or for instance, they're trying to actively conceive, reducing their ejaculatory volume would obviously interfere with that. You can just stop the medications and their ejaculation should go back to normal. 5-alpha reductase inhibitors, medications like finasteride, in the 5 milligram dose, Proscar is a medicine that's been used for a very long time in urology to reduce the progression of BPH primarily by shrinking the prostate over time. That process takes about 6 months. It is widely used in urology, just not in my office, because it carries a lot of potential for sexual side effects. So some things that have been reported, certainly you can see a decline in libido. Patients have reported decreased penile sensation. erectile dysfunction, and it's also been associated with certain cognitive and mental health decline, anything from brain fog to depression, anxiety, and even suicidality. So I'm not a big fan of this medication, but it is something that you may come across if you're interacting with other urologists. Daily tadalafil. This is a medication I love. Tadalafil is the generic for Cialis, which many people use on demand to help with erectile function. But there is a low dose daily 5 milligram tablet you can put a patient on. It helps to relax the smooth muscle in the bladder and in the urethra to help with urinary symptoms. It also has a secondary benefit of helping with erectile function. It's an endothelial stabilizer, so it is also pro-cardiovascular health. So for a variety, all of these reasons, it's a medication I use quite frequently in my office, and it's of course not associated with any kind of sexual side effect. I bring all of this up to point out that when you're talking to patients about treating their urinary symptoms, what you choose to use should align with their sexual health priorities. They may be talking to you about their urination, but you should be asking them about their sexual function, knowing that some of the medications you might use could have a negative impact on that. You also want to consider drug interactions. So alpha blockers can sometimes interact with some of the HIV drugs that get prescribed, leading to either increased or decreased levels of that alpha blocker in their bloodstream, which can potentially lead to side effects. A word on renal function. So patients living with HIV are at higher risk of acute kidney injury and chronic kidney disease. This is for a few reasons. There's direct viral effects. There's this sort of chronic immune activation, inflammation milieu we've been talking about. Even when the viral load is suppressed by medication, this can still contribute to damage to the kidneys over time. Some of the medications used in the treatment for HIV can be nephrotoxic, and then, of course, the comorbid conditions we've been talking about today. In terms of stones in the urinary tract, HIV can alter urine composition to favor crystallization and eventually stone formation. So that can happen to patients over time. And then some HIV drugs, especially some of the older ones, are known to increase stone risk. I want to briefly transition into talking about urological malignancies. So as people are now allowed to live longer with this virus, there's been a shift from AIDS defining to non-AIDS defining cancers. And again, this is due to chronic inflammatory state, immune dysregulation, things like smoking, and of course, HPV. Cancer is now a growing cause of morbidity and mortality for this patient population. So these are some of the cancers that I deal with. Prostate cancer, as we mentioned earlier, there's an incidence that's either similar or slightly lower in HIV positive patients compared to their HIV negative peers. There is often a more advanced presentation at the time of diagnosis. Again, we think probably because they're not interacting with the screening process as often. Lower PSA levels may also delay detection. So PSA in the last 10 to 15 years has gotten a lot of flack. Initially, we screened routinely patients every year after the age of 50 with a PSA and a digital rectal exam. The US task force, this is back when I was still in residency, so more than 10 years ago, came out and said basically to abandon PSA screening, which many urologists were not happy about. So instead, what we've been doing since then is following this sort of shared decision-making approach to screening patients for prostate cancer, which essentially means you need to evaluate the patient, their comorbid conditions, their age, and risk factors like if they have a family history, if they're African American, which put them at slightly higher risk of having prostate cancer, and discussing all of these things with them and coming up with some reasonable strategy to screen them regularly for prostate cancer. What about bladder cancer? So bladder cancer tends to be a disease of aging individuals. However, patients with HIV often present younger with bladder cancer and often with higher grade and higher stage disease. So hematuria in an HIV positive patient should never be ignored or simply written off as related to an infection, especially if it's gross hematuria. They need to be referred to a urologist. They need to undergo a formal evaluation, including a cystoscopy and upper tract imaging. Microscopic hematuria should probably still have a referral to a urologist. The new guidelines for microscopic hematuria have recently changed where we try to risk stratify patients a little bit better so that a low risk patient is probably not going to initially get a cystoscopy. Although one can make the argument that someone who is HIV positive kind of puts them outside of being a traditionally low risk patient. What about HPV-associated malignancies? So there's a higher prevalence of high-risk HPV in this population, which puts them at increased risk of penile and anal cancers, which means that part of your annual physical or routine health checks with these patients should involve a genital and perianal exams. HPV vaccination can also be quite beneficial to this population. Renal and upper tract malignancies. So there is possibly an earlier presentation in this cohort, and that may be related to the chronic kidney disease risk, as well as ART-related nephropathy that they face. Again, hematuria can sometimes be the harbinger of something very bad happening in the urinary tract, so it's not something you want to ignore, and would definitely want to follow up with some sort of imaging of the upper tract. So I wish I could give you better guidance in terms of how can you screen these patients, but the reality is, other than prostate cancer, there are no guidelines for how to screen patients, even in the general population, for renal or upper tract cancers, bladder cancer. And there's no difference in someone and their HIV status in terms of how you should be screening them for these genitourinary cancers. So we want to just follow the general population guidelines. However, you should have a lower threshold for evaluation of red flag symptoms, some of which I kind of mentioned today. Certainly, if you see hematuria, or even if you have a low, a borderline PSA level, if that patient, happens to be African American or have a family history, your threshold for referring them for a more formal evaluation should probably be lower. All right, switching gears to infections. So there is quite a bit of a symptom overlap between urinary tract infections, sexually transmitted infections, and prostatitis. Recurrent infections in this group are more common, and we see STI risk persisting into older age more commonly in this group than in the general population. So when we talk about routine STI screening, it's important to screen all sexually active older men, regardless of age. And that should include screenings for syphilis, gonorrhea, chlamydia, and of course, HPV-related disease. When we think about vaccinations, HPV, hepatitis A and B, COVID, flu, meningitis, and Mpox can all be very important. And when you counsel patients, you want to talk to them about safe sex practices, partner notification, and of course, HIV prevention medications for negative partners who may be at risk. How do we evaluate someone who comes in with urinary tract infections? So if you're seeing recurrent UTIs or a history of prostatitis, you want to think about obstruction, right? That person may not be emptying their bladder well. That urine is sitting stagnant in their bladder. It's growing bacteria and leading to some of these infections. So you need to rule out obstruction. And we can do that through a variety of methods, having them do a uroflow in our office, which measures their flow rate, doing a post-void residual, performing a cystoscopy to look at how obstructive their prostate appears. All of those can be helpful to evaluate someone for obstruction. Generally, UTI prophylaxis is not indicated in this patient population. You want to use targeted antibiotics. So one thing that I see very commonly, and this occurs in my male patients and female patients, someone comes in with irritative voiding symptoms. They go to an urgent care. That urgent care does a point of care urine dip, and which can be very unreliable and are empirically started on antibiotics when they may not in fact have an infection. So I see a lot of my prostatitis patients who have more of an inflammatory prostatitis picture, or maybe even pelvic floor dysfunction as the cause of their symptoms, and have been placed on rounds and rounds and rounds of antibiotics. So I, generally do not recommend empirically treating symptoms. If possible, assuming someone is not, febrile and really sick, wait for the culture, see what the pathogen is, use targeted antibiotics appropriately. If you find someone has obstructive symptoms or is having recurrent urinary tract infections, alpha blockers would be a first-line therapy to start on these patients. And then, of course, if they can't tolerate alpha blockers, if they continue to have infections despite alpha blockers, if they have rising post-void residuals, that's when you want to start thinking about surgical interventions done often transurethral. Okay. Pelvic pain. So this, for whatever reason, has become a very big part of my practice. I seem to be like the male pelvic pain person in Los Angeles. But it's interesting because pelvic pain is a component of chronic pain, and we know that non-malignant chronic pain is very common in patients with HIV, as we heard earlier today. Chronic pain prevalence rates are higher in people with HIV than the general population. And this may be due to several factors, which include this sort of chronic inflammatory state that we continue to talk about, medication related neuropathies, recurrent infections, STIs, and prostatitis. I would add into that pelvic floor dysfunction, which is something I see very, very commonly as a source of pelvic pain. Urinary incontinence. So when we talk about incontinence, we try to qualify what kind of incontinence it is. So there's urge incontinence, there is overflow incontinence related to incomplete emptying, essentially, and then functional incontinence. Contributors include the lower urinary tract symptoms, sometimes neuropathies or neurological conditions, and medications can cause these issues as well. Men are notoriously bad about sharing details when it comes to their urological and sexual health. And we know that men in general don't like to talk about leaking. So you have to ask about it. This is not well understood in HIV positive patients specifically, but I can tell you just men in general do not want to volunteer this information. So it's important to ask, especially if they're talking about obstructive symptoms or even overactive symptoms, asking them, do you ever have problems with leaking? Do you, and a lot of times they will mention, oh, I get to the house, I turn the key in the lock, and you have to run to the bathroom, and I might leak a little bit. So you want to understand that, because is it something like that, which we call latchkey incontinence, or are they having to wear, Depends during the day because they leak quite a bit? And if you don't ask about it, you may not know. Okay, how do we manage incontinence? Well, so for mild cases, you can refer them to a pelvic floor physical therapist to work on strengthening their pelvic floor. Or if they have an emptying problem, actually learning how to relax their pelvic floor can be really helpful. You could talk to them about timed voiding, adjusting dietary intake, so limiting caffeine, alcohol, spicy foods, acidic drinks, all which are known to irritate the bladder. It's important to talk to them about weight management if they happen to be overweight or obese. If they're smokers, that can also be a bladder irritant. For a number of health reasons, they should stop smoking, but this is another one. You can consider pharmacology. So anticholinergics have been around for a very long time. The newer ones tend to be better tolerated than some of the older ones, which could cause dry eyes, dry mouth, constipation. And there was a lot of drop off in terms of compliance with those medications because of the side effects, which we don't really see with some of the newer anticholinergics. There's also beta-3 agonist medications like mirabegron, I think is the generic, but Mirabetrix is the brand name, which can be helpful and don't tend to carry the same side effects. Can also be used safely in older patients, because anticholinergic therapy long-term can sometimes increase the risk of dementia or cognitive decline as people age. So thankfully, we can use the beta-3 agonists. All right. You can treat bladder outlet obstruction. So TURP stands for transurethral resection of prostate. It is sort of the gold standard. It's been done for 40 plus years. A lot of people may have heard lots of different things about TURPs. They used to be quite morbid back in the 80s and 90s when the visualization was bad. Patients routinely had to get blood transfusions related to these surgeries, sometimes stayed in the hospital for days at a time. It's essentially now an outpatient surgery. So I keep my patients overnight in the hospital to have a continuous bladder irrigation system connected to their catheter. But other than that, they could go home with their catheter. The next morning I come in, remove their catheter, and almost immediately they're peeing like they did 15, 20 years ago. So it's an almost immediate improvement. Because TURP carries about a 50% risk of permanent retrograde ejaculation. There have been some newer technologies that have come out in the last 10 to 15 years to try to preserve sexual function as much as possible. There are treatments like the Urolift, which doesn't actually resect prostatic tissue, but sort of lifts it away or pins it to the side so that the urinary channel is more open. Procedures like Resume, which uses a water vapor technology, aquablation, these all carry a much, much lower risk of ejaculatory dysfunction. And the Urolift, actually, it's like 0% in the study. However, the durability doesn't seem to be as good. So again, this is where sort of patient counseling becomes incredibly important. If they get a TERP, the chances are they will never need another procedure to help them pee again. The durability is 15 years often. With a Urolift, a Resume, an aquablation, they should just know that we just don't have the data because these technologies have not been out for that long. And so if they are willing to maybe have to restart a medication at some point or consider an additional procedure, they may prefer that to continue to preserve their ejaculatory function. With overactive symptoms, there are treatments like interstim neuromodulation and temporary tibial nerve stimulation, which can help regulate the bladder nerves. Intravesical Botox is used for sort of more severe or refractory cases of overactive symptoms. For patients who leak, there is a male sling, which involves us inserting mesh to support the urethra. This is good for mild to moderate stress incontinence compared to an artificial urinary sphincter, which is a little bit more complicated of a surgery, which involves a fluid-filled cuff being placed around the urethra, which is controlled by a pump that sits in the scrotum. And this is more useful for more severe leakage. Okay, let's get on to the sex stuff. So hypogonadism in HIV, some of this has been covered already, so I'll try to go quickly through this. But the prevalence is around 30% in patients living with HIV. The symptoms many of you are familiar with. I will add this to it. Hypogonadism, we often think about as like related to sex and energy and muscles. And of course, those things are incredibly important. But brain fog, memory problems, trouble sleeping, lack of motivation is one I hear a lot. People just don't want to do things in life anymore, I think are some of the more harmful symptoms that people experience and sometimes don't get asked about. And so you might see a guy that looks super muscular and doesn't really complain about energy. And if you're not asking about potential cognitive decline or mental health struggles or how they're sleeping, you may be sort of missing the boat there. SHBG, we talked a little bit earlier about this. It's an incredibly important thing to evaluate or to measure because it can mask low free testosterone, which is really the more important marker when you're evaluating someone's testosterone health. Okay, so when you're considering what to put someone on, you want to assess the benefits, right? Obviously, and the risks associated with this, which we had a great talk about a little while ago. You want to consider cardiovascular factors. And then the last thing is really important. And I see way too many men get put on testosterone replacement therapy and never be counseled on the fact that it is going to plummet their sperm counts and that they may have difficulty having a child in the future. And so just because someone is gay or has HIV does not mean that they don't want to have kids. And you need to counsel them on the potential negative effects of testosterone replacement therapy. There are, thankfully, other treatments that we can sometimes put people on to boost testosterone production endogenously that does not complicate that. So we often will consider those in younger men or men who want to preserve their fertility. You need to monitor hematocrit, PSA, lipids, which we talked about earlier. And again, we sort of follow a shared decision-making process here. Okay, erectile dysfunction. So this is a multifactorial problem. The nuts and bolts of it are that it involves vascular function, hormonal function, and obviously psychological factors. As a sexual medicine physician, I often take a biopsychosocial approach. I focus a lot on the biology because of my background, but if you don't consider psychosocial factors, you are going to not be able to fully treat and impact that patient's life. There's a lot of interesting data that have come out in the last 20 years that have shown that erectile dysfunction often precedes overt cardiovascular disease. by years. And so I always tell my patients, you're much more likely to present with erectile dysfunction as the initial symptom of undiagnosed cardiovascular disease years before you would have a heart attack or a stroke. So it's sort of the canary in the coal mine. And oftentimes, when I see someone in their mid 40s who has evidence of vasculogenic dysfunction based on our evaluation in the office, I will sometimes refer that patient to their primary, back to their primary, or even to a cardiologist to have a more formal cardiovascular workup. All right, so how do we manage ED? So you can talk to them about lifestyle and risk factor modification. If they're not getting good sleep, if they're not exercising regularly, if they're not eating sort of a heart healthy diet, those are all things that they can work on. If they have evidence of low testosterone, we fix that. If they have issues related to performance anxiety, if they're depressed, if they're anxious, I try to make appropriate referrals to help them deal with those things because that's going to continue to affect their ability to have an erection. PDE5 inhibitors, Viagra's, Cialis's of the world are incredibly helpful. I put a lot of patients, as I mentioned, on daily tadalafil. You can combine that with an on-demand dose as well. That combination will often work better if someone finds the daily dose unreliable, or even if they find the on-demand dose alone unreliable. You can use that combination safely, even if the pharmacist says that they won't fill both medications. They trust me, they can be used safely. Intracavernosal injections are sort of next in line for medical therapies. That involves injecting a vasoactive substance that vasodilates the cavernosal arteries of the penis. They get injected directly into the corpora. It sounds terrible. I have a lot of patients who are very reluctant to do injections, and then we bring them in the office, do the injection with them, and they're surprised at how easy it is to do. These do carry a very real risk of priapism, whereas the pills do not, even though the commercials say that they do, they don't. ICI does carry the risk of priapism. So in my office, we do their first injection together. We assess their response, and we prescribe an appropriate dose of that substance and strength of that compound to them as an individual. Where I see patients getting into trouble is when they use their partner's intracavernosal injection medication, or they go to a party and someone injects them with this, and then they end up at Eisenhower ER having blood drained out of their penis, and it's a nightmare. So you want to counsel patients on the risk of priapism. If it happens to them, they are a real risk for permanent erectile dysfunction. So they need to be very careful with this. I actually teach all of my patients how to inject phenylephrine as a reversal agent so that if they end up with a prolonged erection, they have the ability to reverse it themselves. There are regenerative therapies, which are very exciting, some of which we do in my office, using low-intensity shockwave therapy and now bipolar radiofrequency that promote angiogenesis in the penis and also neocollagenesis, which helps the tissue function better. And it's not listed here, but surgery is always an option. So someone who has pretty severe vasculogenic erectile dysfunction, especially if it's a venous leak picture, medications are going to be very limited because all of the medicines that we have work on inflow of blood. They vasodilate, but some people don't have an inflow problem. They have a trapping problem. And so penile implant surgery is often the gold standard for those patients. All right, ejaculatory dysfunction. So it's highly prevalent, but rarely discussed. We tend to focus on sex as it relates to erections and not ejaculation. Ejaculatory dysfunction includes low volume ejaculate, delayed and premature ejaculation. It has a significant quality of life impact. And this is something that I learned from my patients. It's something that even in sexual medicine, as a sexual health provider, I wasn't really taught to ask about or not focus on. And it was patients teaching me over the years that this was a really important thing that I should pay attention to. So low volume ejaculate, it can be related to hypogonadism, medications, or obstruction of the outflow of the ejaculate. We see it commonly as people get older. It's a fact of growing older. The amount of volume that you produce goes down. We can evaluate it looking at a semen analysis, which will give you a quantitative amount of volume. We also evaluate patients' hormones because it can be influenced by things like low testosterone. You want to treat reversible causes. So obviously they have low T. You don't want to necessarily put that person on testosterone replacement therapy because that exogenous form of testosterone can actually make the problem worse. So instead, we put them on medications like Clomid or HCG, which are fertility drugs that stimulate endogenous production of testosterone. Obviously, if they have some sort of obstructive pattern, you can do an ejaculatory duct resection to help the fluid get out easier. And there's a growing interest in the role of supplements. Certain ingredients like zinc, L-arginine, pygeum, lecithin have all been associated with increases in volume. And that's primarily come out of the reproductive literature. Delayed ejaculation. So this can commonly be caused by antidepressant medication, specifically SSRIs. But there are other factors like neuropathies and psychological factors which can play a role here. It is also age-related. So it becomes increasingly hard for men to ejaculate or cross that orgasmic threshold as they age. And that's probably related to lots of different factors, some of which include decreased penile sensitivity, as well as a decline in hormonal function. The treatment for this condition is probably one of the most challenging things that I see in my practice because there's not one size fits all. There's no one drug that I can put a patient on to fix this problem. We have to employ hormonal treatments, medications like oxytocin, often use dopamine agonists. Stimulants can help some patients. If they're having concurrent problems with their erections, we'll put them on PDE5 inhibitors or intracavernosal injections. And then again, we're starting to employ regenerative therapies and products to help with this issue. Premature ejaculation is actually the most common type of sexual dysfunction in men. It affects 30+% of men in the general population. It can be lifelong or acquired, and sometimes can be related to erectile dysfunction or performance anxiety. If they have concomitant ED and premature ejaculation, we always treat the ED first because a significant number of those patients will see a normalization of their ejaculatory function by fixing their erections alone. In terms of treatments, we talked to them about behavioral modification, so sort of slowing down the excitation that their brain senses during arousal. You can talk to them about barrier methods. Things like condoms can be incredibly helpful because it creates a barrier between the penis and their partner. There are topical numbing agents that can desensitize the nerves in the penis and make it easier for patients to control their ejaculation. And then pharmacological options. So there's no FDA-approved strategy for treating premature ejaculation or really any ejaculatory disorder. So everything we do is off-label. There is a drug in Europe and outside of the US called duloxetine, which is an on-demand SSRI that has been quite successful, but it's just not available here. So we use the SSRIs that we do have. The one that has the most data is Paxil. And so we'll put the patient on a daily Paxil because one of the side effects of those medications is that it causes delayed ejaculation. So we use the side effect to our advantage in this case to help men have better control. Tramadol, I also put up there. It's a medication that's used in pain that works on the mu receptor, and that sort of you should think about as sort of breaking the connection between or disrupting the connection between the genitals and the brain so that someone can have a little bit more control, and that's something that they take on demand prior to sex. Okay, what about fertility and reproductive considerations? So when you talk about HIV transmission risk, that has been virtually eliminated with modern techniques like sperm washing, ICSI, ART, and PrEP. You always want to discuss cryopreservation prior to starting someone on testosterone replacement therapy or consider other types of treatments to increase endogenous production. And if someone don't hesitate to refer to reproductive specialists when fertility is a priority for a patient. Okay, I think we're almost done. So in terms of ART, drug-drug interactions and how they interact with the medications that we prescribe, so many ART agents interact with the CYP3A4 and other pathways, which, as I mentioned, can lead to increases or decrease levels of these drugs that we use. PDE5 inhibitors may need to be adjusted as may alpha blockers in patients on these medications. And so it's really important to have a good relationship with your HIV clinician, with an HIV pharmacist when prescribing hormones, PDE5 inhibitors, and the medications that we use for BPH. So thank you for listening. Here are some of the key takeaways. HIV is an independent risk factor for many urological and sexual health concerns. Urological and sexual health issues are largely treatable with appropriate diagnoses. Ejaculatory symptoms deserve routine screening. That's my big soapbox moment. Treatment decisions must integrate sexual and reproductive priorities for all patients, no matter their age or HIV status. Be cautious of drug interactions. And as with many things in medicine, a multidisciplinary care approach tends to improve outcomes. So rely on your colleagues. That's it. Thank you.
Great job. Very, germane and important topic, isn't it, that we see in our patients and, complicated. So it's important to sometimes just go to the expert. But one thing immediately that struck my head is how often we treat what we think are urinary tract infections in patients. They almost tell us, I have a UTI, give me this,